Hello, everyone, and thank you for joining me today. I'll be presenting a case study on Sue, an 8-year-old girl who demonstrates symptoms of both separation anxiety disorder and possible selective mutism. In this presentation, I'll review her presenting symptoms, possible diagnoses using the DSM-5-TR, environmental and cultural factors, and appropriate home and school interventions supported by current research. Sue displays several signs of anxiety that interfere with her daily functioning. She cries and throws tantrums before school, complains of stomach aches and headaches, and often vomits or breaks out in hives when separation from her mother is imminent. She also expresses persistent fears that something bad will happen to her family. At home, she is outgoing and talkative, but at school she is withdrawn and isolated. These behaviors align with clinically significant separation anxiety and may overlap with selective mutism features. According to the DSM-5-TR, separation anxiety disorder involves excessive fear or anxiety about separation from attachment figures, lasting at least 4 weeks in children and causing significant distress or impairment. Sue meets several criteria: recurrent distress when anticipating separation, persistent worry about harm to loved ones, refusal to attend school, and physical symptoms during separation episodes. Her symptoms have persisted over multiple school years, demonstrating both duration and impairment criteria. Selective mutism is defined as a consistent failure to speak in specific social situations despite speaking in others. Although Sue is not described as completely mute at school, her limited social interaction and lack of friendships may point towards subthreshold or comorbid selective mutism. Differential diagnoses to consider include social anxiety disorder, specific phobia related to school, or communication disorder. A full diagnostic interview and observation at school would help clarify this. The two most likely diagnoses are separation anxiety disorder and selective mutism, provisional. Separation anxiety disorder best fits her pervasive distress about separation and physical symptoms, while selective mutism may explain her restricted verbal engagement in school contexts. Both conditions often co-occur in early childhood and are rooted in anxiety. Determining the relative contribution of each will guide treatment emphasis. Sue's anxiety is shaped by a mix of environmental, cultural, and potential genetic factors. Her mother's work from home arrangement and tendency to allow Sue to stay home reinforce avoidance behaviors. The grandmother's cultural perspective, emphasizing eating bitterness or enduring hardship without complaint, creates tension between generations about how to handle emotions. Culturally, Chinese families may view mental health difficulties as personal weakness, increasing parental guilt and delaying treatment. Finally, a family history of anxiety or temperament traits like behavioral inhibition may predispose Sue to anxiety. A comprehensive assessment should include structured diagnostic interviews such as the ADAS-CP, teacher reports, and observation at school. DSM-5-TR anxiety severity measures and the selective mutism questionnaire can help assess intensity and situational triggers. Additionally, a medical exam should rule out organic causes for Sue's somatic symptoms. Collecting data from both home and school ensures a full picture of her functioning across settings. The SPACE program, or Supportive Parenting for Anxious Childhood Emotions, developed by Lebowitz and colleagues, helps parents reduce accommodation behaviors and promote independence. Parents are coached to express confidence and empathy without reinforcing avoidance. Establishing consistent routines using positive reinforcement for small separations and replacing bribery with structured contingency plans will gradually build Sue's tolerance for separation. Collaboration with Sue's school is critical. Teachers and counselors can implement gradual exposure strategies, such as shortened school days or check-ins with a trusted staff member. Predictable transition cues and supportive environments can ease anxiety. The school nurse should avoid sending Sue home unless truly necessary. Her anxiety significantly impairs attendance or testing. A 504 plan can ensure appropriate accommodations while supporting attendance goals. Direct treatment should focus on exposure-based cognitive behavioral therapy, tailored for childhood anxiety. Sue can learn emotional regulation and relaxation techniques like deep breathing and mindfulness to manage physiological symptoms. If selective mutism behavior persists, behavioral techniques such as stimulus fading, starting speech in comfortable contexts and gradually expanding, shaping, and contingency management can help build a verbal confidence across settings. Culturally sensitive counseling will help bridge the gap between Western therapy and Sue's family beliefs. Using an interpreter or translated materials for the grandmother can help her understand the treatment process. The counselor should frame therapy as a strength-based approach to building courage rather than as weakness. Family sessions can address the father's guilt and cultural stigma, ensuring all members support Sue's progress consistently. Research strongly supports both CBT and parent-based interventions like SPACE as effective for childhood anxiety. Behavioral protocols and intensive group treatments have demonstrated positive outcomes for selective mutism. With coordinated efforts among the family, school, and therapists, Sue's prognosis is positive. She can develop independence, social comfort, and coping skills that foster both academic and emotional success. These are peer-reviewed and evidence-based sources supporting today's presentation, including the DSM-5, TR, and key studies by Lebowitz, Cornacchio, and Pereira between 2019 and 2023. In summary, Sue's case highlights the importance of understanding the intersection of anxiety, culture, and environment in childhood disorders. A combination of family-based support, exposure-focused CBT, and school collaboration offers the best opportunity for Sue's recovery. Thank you.